It's 8 a.m. Atlanta time, 3 p.m. Amman, Beirut, Hebron time. Good morning, good afternoon. It's my pleasure to introduce to you our speaker today, Dr. Osama Hamid, consultant in minimally invasive and bariatric surgery and chief of general surgery at the Arab Medical Center in Amman, Jordan, secretary of the prestigious American College of Surgeons. It has been my honor and pleasure to get to know Dr. Hamid and recognize his leadership in surgical practice, education, research, and training. And Dr. Hamid has been very kind to volunteer his time and effort to give us a lecture. I have had the pleasure of reviewing the slides. The material is exceptionally rich and very valuable. It addresses a very important issue, which is cardiovascular disease, as it is impacted by obesity, hypercholesterolemia, diabetes, and hypertension. All of those are exacerbated by obesity. And to our good fortune, there is a surgical approach that Dr. Hamid has been pioneering in the region that addresses those problems in the overweight and obese patients. Dr. Hamid, welcome. Thank you very much. And please take it from here and speak for the next 30 minutes and then 10 minutes for question and answer. Dr. Hamid.
Well, thank you, Dr. Latouf, for this opportunity. Actually, as we just have discussed before we starting, this is really a great idea. Knowledge is something God created to share among humans, and sharing it without borders limitation. It's really a very, very intuitive idea, and I'm really into it. And this is great effort. I'm really honored to be part of this great effort. As Dr. Latouf said, today I'm going to touch on the impact of bariatric surgery on type 2 diabetes and risk of cardiovascular disease. As you all know, obesity is becoming a worldwide epidemic, and there is really a good solution for this obesity as a major risk factor for cardiovascular disease. Some of you would ask why a surgeon is talking about management of cardiovascular risk factors and type 2 diabetes. So this is my disclosure. I'm a surgeon, so I'll be biased toward surgical approach for this two main problems that happens worldwide. But don't forget that Dr. Banting was a surgeon, and those who don't know Dr. Banting, he was an orthopedic surgeon, and he was the one who discovered insulin, and he had a Nobel Prize for his discovery. So again, surgeons used, or at least invented, the most important drug for treatment of diabetes, and I think we are coming back as hopefully the modality to treat diabetes down the road. So what is obesity? The WHO definition is a disease in which excess fat is accumulated to an extent that health may be adversely affected. This was recognized in the WHO in 1979, and recently, let's say like for the last 10-15 years, was also recognized by the American Medical Association as a disease entity with an ICD code. How we classify obesity, most of you know the body mass index, which is the weight in kilogram divided by height in meters. This is actually the best tool that we have so far to classify, identify obesity. With people with a BMI less than 18, this is considered underweight. The normal acceptance range is between 18 to 24. More than 25 to 30, this is called overweight. Above 30, this is what we define obesity with its classes. Class 1, 2, 3, 4, 5 depends on the basically the degree of BMI. BMI class 3, it's called morbid obesity, and that's very important to understand. In terms of childhood obesity, it actually depends on the percentile on the growth charts that's available in the pediatrician clinics. Obesity is really a complex disease where there are so many genetics as well as environmental factors intermingled to each other and results in the increased prevalence of obesity. But we can really go down to the most basic understanding, which is it's an imbalance between how much you take and how much you expend in terms of energy. So something to keep in mind, could be defined as simple as that, but actually it is more of a complex disease with a lot of other factors playing into it. So again, we know now there are multiple genes involved in the, let's say, the weight management and weight control for these patients in the brain, gut, liver, muscles. And then there's the FTO genotype that was discovered recently, where, again, people with abnormal copy of this genotype are more likely to be obese than other people. Again, it is much more complex than just increase energy, increase intake, and decrease expenditure. There are so many environmental factors, as you can see, starting at the international level, from globalization of markets and the economic development that happens, to the national level, in terms and regional level, health policy, food policy, transport policy, education policy, and it goes down to the individual level of that just sedentary lifestyle with no real exercise and high intake of junk food. So all these factors, genetics, environmental, at all levels, really results in the prevalence of obesity. The WHO in 1998 had expected that in developing countries, as their economies grow, non-communicable diseases like obesity as well as diabetes would increase, mainly from the adoption of Western lifestyles and their combining risk factors, smoking, high-fat diet, and lack of exercise. And this was back in 1998, and actually they were really true about that. If you look at, let's say, the Middle East area as well as the North America, you will see we are actually the most obese nations, and this is the 2008 WHO report of obesity, and these are where obesity rate above 30%, Jordan, Saudi Arabia, the Gulf, Egypt, Algeria, North America, Mexico, we are considered an obese nations from the WHO classification. So our world is getting fat, and again, I think fatter and fatter, unless we interfere to put some real policies at the level of real countries to solve this problem. The message that I want to see, this is a clear message that obesity shortens life. And if you look at this very nice study where compared with a normal height, weight individuals, a 25-year-old morbidly obese has a 22% reduction in his expected remaining lifespan. This is very striking and very, very important to keep in mind. Why is that? It's because obesity is a risk factor for all known metabolic disorders that we're aware of: cardiovascular, hyperlipidemia, hypertension, diabetes, arthritis, cancer, sleep apnea, everything. Obesity plays a major role in its pathophysiology as a risk factor. The way we approach obesity actually should comes onto different levels. I think the most important of it is prevention, which is lifestyle changes in exercise. The next level is trying some medical therapies that some people are trying to find some drugs for it, but so far they're not being that successful. And then the final thing is bariatric surgery comes in. Again, the most effective and most sustainable, but it's very important to keep in mind that bariatric surgery by itself, it's not the magic bullet. I think you have to have lifestyle modifications to have a successful bariatric surgery. So again, this is how we approach obesity. We should start with prevention. I think it's the most important thing, and this is where we have to invest. But then medical therapy is something we have to invest in. But again, bariatric surgery provide a very cost-effective way of controlling and treating obesity. This is the NIH criteria for indication for bariatric surgery. It's an BMI of 40 or higher, regardless. BMI of between 35 to 40 with at least 2 obesity-related comorbidities, including diabetes, hypertension, coronary artery disease, hyperlipidemia, dyslipidemia, gastroesophageal reflux. All these are considered obesity-related comorbidities, and it's very important to keep the last thing in mind, that the patient had tried other modalities and he had failed. This is very important to keep in mind. There are 2 main bariatric surgery types. We have the restrictive types. They really mainly work by restricting the amount of food that you can eat, so you feel full very quickly, and that results in a gradual weight loss down the road. We have the most commonly performed procedure now in the middle called sleeve gastrectomy. The vertical banded gastroplasty is an obsolete, not done anymore. And then the gastric band, that I think it's going to be an obsolete down the road. This is beyond the topic of this lecture, but again, sleeve gastrectomy is really the most commonly performed bariatric procedure worldwide nowadays. And then the other type of bariatric operations, which are the malabsorptive or hybrid procedures. They have an element of restriction by creating small pouch in the gastric bypass or the sleeve gastrectomy in the biliopancreatic diversion, and then they have some sort of malabsorptions associated with them, depends on the type of the procedures. So again, these are the two main types of bariatric operations. This is how we measure outcomes of bariatric surgery. It's really the amount of excess weight loss that patient had lost, and then also we look at the resolution of comorbidities and very important patient satisfaction. This is how we measure excess weight loss. Typically, there's an ideal body weight charts, depends on the patient age and sex. You can find these charts online, they're free. So you do calculate the excess weight the patient has based on his current weight minus the ideal body weight, and then every time he visits you, you look at the amount of excess weight, the percentage of excess weight loss, which is excess weight minus amount of weight loss over the excess weight by 100%. The number that we're looking for, where most of comorbidities actually resolve, is if we lose more than 60% of our excess weight loss. Very important to know is bariatric surgery becoming a very safe operation. And I'm sure most of you are aware of the, let's say, huge trend toward more patients are requesting this operation. It's mainly because of safety, and it's done now laparoscopically with a very low mortality rate of as low as 0.08%. Again, more major operations like biliopancreatic diversion has a higher mortality compared to other procedures like sleeve gastrectomy and gastric bands. Over many years, multiple studies were done, and bariatric surgery had always stood superior compared to non-surgical methods. It resulted in a greater weight loss, resulted in a better improvement in metabolic diseases, resulted in lower mortality rate, and actually it also has a lower cost compared to other medical therapy for obesity. This is the, I think we'll touch on this trial. This is the most well-controlled prospective trial done for obesity treatment. It's a Swedish obesity study group where they really followed patients for 20 years after having bariatric operation, and you can see weight loss is really much better compared to conventional medical therapy. So regardless of the type of surgery that you have, it's definitely better than conventional medical therapy. And also this resulted in a reduction in mortality. If you look at the control group here, their mortality over 5 years was as high as 6% compared to 0.68% in the bariatric group. So this is a result in a significant reduction in relative risk of death by 89%. The way we approach obesity should be a multidisciplinary team management. It's not the bariatric surgeon, nor the endocrinologist, nor the cardiologist actually who can take care of these patients by himself. It's a multidisciplinary team effort where everybody has its impact and effect on patient outcome, including nutritionists, bariatric surgery coordinators, fitness trainer, bariatric internist, cardiologist, endocrinologist, pulmonologist, gastroenterologist, psychologist, as well as the bariatric surgeon. So it's very important to have this team approach to get the best results for bariatric surgery. Well, let's go into the theme of the main topic of our lecture today, which is bariatric surgery and impact on cardiovascular risk factors. We are all aware of these risk factors for cardiovascular disease: obesity, smoking, hypercholesterolemia, hypertension, stress, high protein, all these known risk factors, male factors, family history, all these are non-risk factors, and the way we look at it and see how obesity affects other risk factors in improving cardiovascular disease risks down the road. This is again to summarize the Swedish obese subject study. I think it's the most well-controlled prospective trial that was done in bariatric surgery with a very high follow-up rate. It reached almost 99% complete follow-up rate that reached up to 20 years nowadays. So this is very, very important to keep in mind, and it's the main study that most people refer when they look at bariatric surgery in general in a community level. This is their publication about effect of bariatric surgery. This was the 10-year data on risk factors that we are known for cardiovascular disease. You look at hypertension, the rate of recovery for the control group was only 22% at 2 years, compared to 60%, 62% at 10 years for at 2 years for the bariatric surgery. At 10 years, the effect of bariatric surgery decreased, but again, still much higher than the control group. Same for the low HDL level. At 2 years, bariatric surgery was superior to a control group, and this superiority persisted after 10 years, or 73% resolution of their low HDL compared to 53%. If you look at diabetes, there were at 2 years a very, very dramatic improvement in diabetes for the surgery group, 72% compared to 21% only for the control group. And for the 10-year follow-up data, the diabetes effect had decreased, but still much higher than the control group. Same as for hypertension and hyperuricemia. So by doing a bariatric surgery on these patients, you know that you will significantly affect their cardiovascular disease risk factor, and this will result in reduction in their cardiovascular events. And this is their 2013 publication. They compared the rate of fatal cardiovascular events in the control group compared to the surgery group, and you can see that surgery group had a much lower rate that was statistically significant compared to the control group, and that was also evident for the total number of cardiovascular events in general. The surgery group has much lower cardiovascular events compared to the control group. So this is another large systemic review in the subject, almost 19,000 patients. 44% of them reported some sort of hypertension. 2/3 of them, they had resolution or improvement of their hypertension after bariatric surgery. And we know hypertension is a very important risk factor for cardiovascular diseases in general. And there was a reduction of the 10-year Framingham score for coronary artery disease from 5.9% to 3.3%. Again, this is a significant reduction in the coronary heart disease Framingham score at 10 years in the patient who had bariatric surgery compared to the patient who did not have bariatric surgery and had the best medical therapy at that time. And again, the main impact of bariatric surgery is on the risk factor for these group of patients. In terms of effect of bariatric surgery at the rate of myocardial infarction, again, you can see there's a significant improvement of patients who had bariatric surgery compared to the control group in the risk of their myocardial infarction rate by Romeo in 2012. This is regarding the cardiovascular effect and the impact of bariatric surgery on the cardiovascular risk factor. The story is actually more interesting for patients with diabetes. And if we all know that type 2 diabetes is becoming also an epidemic worldwide. In America, there's more than 14 million diabetics. 90% of them are type 2 with insulin resistance as the main pathophysiologic mechanism for it. Same in Jordan and the Middle East. Is, as you can see, the green line is where the highest rate of type 2 diabetes, and basically Jordan Gulf area is considered part of this epidemic. This is a publication from our diabetic center. Our type 2 diabetes is ranging for up to 17%. Patients with some sort of impaired glucose tolerance can reach up to 54%. And this is a dramatic increase compared to 1994 data. The natural history of type 2 diabetes starts by some sort of impaired glucose tolerance and then development of diabetes. This goes for several years before being diagnosed, and then the patient tries exercise and some sort of medical therapy. But we all know that diabetes is a bad disease, and with time, patients will develop micro and macrovascular complications, and eventually patients will die from these complications after trying all medical therapy as well as insulin. So we know diabetes is a deadly disease, and we know the ultimate outcome from diabetes is really eventually death from its bad complications. The story for surgery and type 2 diabetes goes back to 1992. Dr. Boris raised this question in the Annals of Surgery. He said, is type 2 diabetes actually a surgical disease? This was based on some observations treating some obese patients with diabetes. And then he followed this with publication in 1995. Who would have thought it? An operation proves to be the most effective therapy for adult onset diabetes. What he noticed is that he did gastric bypass on almost 600 patients. 27% of them had type 2 diabetes. He saw that 80% of his diabetic patients were off their medications, and there's 99% of those with impaired glucose tolerance were normoglycemic and did not progress to be diabetic down the road. I think the most striking thing for him was, if you bring a patient with on insulin, type 2 diabetic obese on insulin, and this is one of his actual patient charts. If you look, his glucose level before surgery was up to 400, and his insulin intake was almost 80 to 100 units at that time. So basically, you do the surgery, and immediately on day 1 after surgery, you will start noticing that their insulin requirements goes down significantly, and most of these patients, by 1 month after surgery, they're off their medication. This is very striking and very important to remember, that after bariatric surgery, mainly gastric bypass, you have a significant and dramatic response to surgery, to the amount of medication and the insulin the patient requires. And this is very important for the endocrinologist in these patients. So basically, he came up with these observations. The correction of type 2 diabetes occurs within days. The correction basically is durable, even though most of these patients remains obese, by definition BMI more than 30. The operation prevent progression for impaired glucose tolerance in 99%, and the correction was less likely in older patients or those with a longer onset of their diabetes. Since Boris' publications, there are many publications touch on the topic, and that showed basically there is significant improvement in patients' diabetes with bariatric surgery in obese patients. And this is, to summarize it, again, we have at 1 year 76% resolution of their diabetes. At 2 years, it ranged from 70 to 90%. But down the road, we see that response, the resolution decrease. I think it's mainly because of most patients goes back to their original lifestyle problems. So the question is why? And we know it's not exercise, neither oral agents or insulin. It's not weight loss. After bariatric, mainly the malabsorptive procedures, it's not really, weight loss does not happen quickly. And it's either due to the change that happens during the bariatric operation, which is either the exclusion of food from antrum, duodenum, or proximal jejunum, or presentation of mid-jejunum with undigested food. And this has resulted in 2 main theories. Again, it's either due to the passage of food directly to distal small bowel, or really the exclusion of small bowel, the proximal small bowel from being in touch with food. We have 2 theories. We have the hindgut hypothesis, and we have the foregut hypothesis. The hindgut hypothesis says that diabetic controls results from the expedited delivery of nutrients to the distal small bowel, and this results in an enhanced physiologic signal that improves glucose metabolism. A very important potential candidate, GLP-1, that's secreted by L cells in the distal small bowel in response to nutrients. This GLP-1 stimulates insulin secretion and results in normoglycemia. The foregut hypothesis actually says that diabetes control depends on the exclusion of duodenum and proximal jejunum from the transit of nutrients. It results in the prevention of secretion of a very important signal that actually promote insulin resistance, and so far we don't have any identified factor to the best of our knowledge. So diabetes is a balance between these incretins that we talked about that promote insulin secretion and promote insulin action, and anti-incretins that really resist these kind of factors. And diabetes happens when there is imbalance between incretins and anti-incretins. This is actually a very interesting trial published in the New England Journal of Medicine. It's surgical therapy and medication to treat patients with diabetes and obese patients by Phil Shower from Cleveland Clinic. Again, 50 patients allocated to medical therapy, 50 patients to gastric bypass, and 50 patients to sleeve gastrectomy. And their endpoint was hemoglobin A1C level less than 6%. These are the patient characteristics. They were all similar among the three groups. And if you look at the resolution of diabetes for gastric bypass compared to medical therapy, that was very statistically significant. Same as sleeve gastrectomy versus medical therapy. But between gastric bypass and sleeve gastrectomy, the outcome was similar. Again, the change in hemoglobin A1C and resolution of diabetes and number of medication was significantly better in patients who had surgery compared to the best available medical therapy. Another trial published on the same issue of the New England Journal of Medicine of comparing surgery versus medical therapy for type 2 diabetes in obese patients. Here they introduced biliopancreatic diversion, gastric bypass, and best medical therapy. And again, there was significant higher rate of resolution of diabetes in the patient with biliopancreatic diversion compared to medical therapy, same as for gastric bypass compared to medical therapy. So the best rate of resolution was with the biliopancreatic diversion, 95% compared to 75% of the Roux-en-Y gastric bypass. And actually, biliopancreatic diversion did much better than Roux-en-Y gastric bypass. And the time of normalization of hemoglobin A1C actually happened earlier with the biliopancreatic diversion at 4 months compared to 10 months for the gastric bypass. Again, this is they did not. I'm finishing. They did not. The bariatric surgery, so either gastric bypass or biliopancreatic diversion, results in also resolution of all other comorbidities or risk factors in this randomized trial for cardiovascular disease. This is very important slide, which is patient with diabetes. What is the effect of bariatric surgery on the cardiovascular risk disease? This had been looked up at again the Swedish obesity study group. They found that in patients with type 2 diabetes, there was a significant reduction in their cardiovascular event by 37%. That's very, very, very striking. In their publication in 2012, they published very interesting data that the incidence of diabetes in the control group versus in the surgical group, those who did not have diabetes to start with, they found that the incidence of diabetes was much higher in the control group compared to the surgical group. And they thought actually bariatric surgery can prevent diabetes down the road in their publication here. So in conclusion, bariatric surgery is the most effective and sustainable way for weight loss in obese individuals. Bariatric surgery in obese individuals results in significant reduction in their cardiovascular risk factors and also results in the highest rate of remission of type 2 diabetes compared to the best available medical therapy. We go back to the slide. Prevention is really the way that we have to invest in as healthcare leaders and nations. And basically, again, the multidisciplinary care, what really matters. And this is, I think, we need a lifestyle changes from our parents. And this is a funny cartoons where really we're transferring our problems to our kids by relying on all these junk foods and these food chains. And thank you.
Dr. Osama, this is a fabulous presentation that you have given us. Thank you so very much for preparing an outstanding lecture that covers the topic. As an expert surgical cardiologist, I have learned a lot from the material that you have presented. And frankly, I'm astounded by the data that you have presented that in patients who have morbid obesity, the surgical gastric diversion reduces mortality at 2 years and 10 years by no less than 1 out of 3, 37%. That is amazing information. I'm going to ask some questions, and I'll let you open it to the audience and then take the questions as they come. Two questions for you. When you do a gastric bypass and you create that blind gastric pocket, what happens to the secretions that come there? Do they drain out or do they atrophy with time? Two, as you have pointed out, that the management of the surgical management of obesity should be a multidisciplinary team approach: cardiologists, surgeons, psychologists, internists, etc., etc. Does that team exist in Jordan? At Emory, we have been trying to promote that. Thus far, we have not been successful. Do you have a team, or do you have plans to establish such a comprehensive team and make it available to the huge obese population in the region? Thank you.
Thank you, Dr. Latouf, for this interesting two questions. Regarding the first question, the gastric bypass and the excluded stomach, actually, most of the essential secretions from the excluded stomach still goes away. Those are the ones that are not affected by the direct presence of nutrients in the gastric mucosa. So basically, the stomach maintain its blood supply, maintain its function for some let's say its endocrine function persists, because it's really the endocrine nature of the organ that what promotes the secretion of these materials. Very important hormone implicated in obesity is called ghrelin. They found that after gastric, and it's usually secreted from the fundus of the stomach in response to the presence of food. They found that basically this hormone after gastric bypass immediately drops significantly in the patient plasma, but because we did not restrict the stomach and the reservoir for ghrelin secretion is still there, basically most patients, their ghrelin level will go up again to its normal level down the road. The thing is different for sleeve gastrectomy, where you take part of the stomach, and there's a dramatic drop in the value, or at least the amount of ghrelin available in the body. This takes longer time for the body to accommodate and have the ghrelin level back again. This is just one interesting part of the endocrine function of the stomach and its effect on obesity. Regarding the multidisciplinary approach, and I can tell you this is what I hope to have. We have a very well-trained bariatric coordinator. I practice in a complex that we have cardiologists, internists, pulmonologists, endocrinologists who are really into treating bariatric patients. And we had issues having the psychologist availability. Eventually, we actually were able to find some psychologists interested, and we're trying to have some collaboration with. But as I told you, as you have said, it's really a very difficult thing to have at one place. But this is our vision at the Arab Medical Center, is to have a comprehensive approach, exactly the way I've done it in the United States. And this is actually, if you don't do it for your patient, I think you're providing them a suboptimal care.
Thank you very much, Dr. Osama. If there are any questions from the audience, we're happy to receive them. I hope that the mics are open for the audience. Dr. Osama, do you have the mics open for the audience?
I'm the one who opened them.
Just double check, I think.
Yeah.
Well, let me ask another question, Dr. Osama, and I will say the question in relation to our interest in jointly expanding.
I think there's Dr. Talib is trying to ask a question.
Someone asking a question?
Yeah.
Assalamu alaikum. Just my question about bariatric surgery in adolescent with insulin resistant. What's the criteria to do bariatric surgery in adolescent?
Okay, so the issue of bariatric surgery in adolescents, it's a very hot topic, especially in patients with poorly controlled diabetes. There are some data from Cincinnati Children's Hospital where they looked into it doing my gastric bypass for these patients. Their data was not encouraging at that time. They had a very high complication rate. And the reason for that, they had pediatric surgeon doing the bypass, the gastric bypass, rather than a well-trained bariatric surgeon. The most, or maybe the largest series for bariatric surgery in adolescents actually comes from Saudi Arabia. Dr. Al-Qahtani publication in the Annals of Surgery maybe 3 or 4 months ago. And he had a very, very, very good result doing sleeve gastrectomies in obese adolescents, especially with those with Prader-Willi syndrome as well as patients with poorly controlled diabetes. So the indications are still the same, but I think it's very important to have a psychosocial specialist with you dealing with the patient and the family when you're dealing with adolescents. Again, this is a life-changing intervention that you have to have make sure the family as well as the patient fully understand, and it's fully indicated.
Hello.
Yeah.
Thank you very much for this informative lecture. It was awesome. I'm not sure I got that part that you mentioned where the bariatric surgery basically prevented diabetes development in some populations and then treated others. So those ones that did not develop diabetes, did they have impaired glucose tolerance or were they just normal subjects?
So these patients who were normal, this is the slide that you're talking about. So basically, these are the patients who did not have diabetes, and basically they followed up those who had surgery versus those who had no surgery, just medical support therapy. And they found the incidence of diabetes in these patients who had just medical therapy or just observation much higher than those who had surgery. They promoted that bariatric surgery in obese individuals could prevent development of diabetes down the road. That's in terms of prevention from the Swedish obesity study group. What was your other question?
I was asking basically, were they did they have those patients? Did they have impaired glucose tolerance in the first place, or they were just like normal obese people?
They're normal obese people.
Right.
No impaired glucose tolerance, no diabetes to start with.
Okay. Thanks.
Any other questions? Dr. Lattouf, any comment?
If there are no other questions, I want to express my appreciation to Dr. Osama Hamid for an excellent presentation and officially invite you to join us as a faculty on TEDNETS and as a permanent contributor. Dr. Hamid, thank you very much for an outstanding lecture.
Thank you, Dr. Lattouf.
Stay in touch.
It was really a pleasure, and thanks for having me in this very nice visionary initiative. Thank you very much.
Great. Well, our time is up. I will say goodbye.